Hello and welcome to the EMSNation podcast. We're your hosts, Faizan Arshad.
And I'm Chris Fullagar.
Happy Wednesday of EMS Week 2017. Next up on our week-long set of podcasts is Demystifying the Surgical Airway by Kevin T. Colopy.
Kevin Colopy is my friend, and he is the current president of the International Association of Flight and Critical Care Paramedics. Mr. Colopy is also the clinical education coordinator of AirLink Vitalink Critical Care Transport.
I really enjoyed this lecture from Kevin, and he did a fantastic lecture at CCTMC 2016 talking about taking a timeout before RSI and how that can significantly improve patient outcomes. And he definitely continued that education technique and ideas by talking about the surgical airway in the pre-hospital space. And of course, this is that procedure which causes immediate sphincter tone tightening in providers. That nightmare scenario where you're unable to oxygenate and ventilate your patient. And really the next step is to proceed down your algorithm for challenging airways and proceed with a surgical airway. He talked about the three different types of techniques: needle cricothyrotomy, Seldinger cricothyrotomy, as well as an open technique. Chris, you and I recently recorded a training video for the New York State Collaborative Protocols on finger scalpel Bougie for the surgical airway.
Yes, and I think that education, practice, rehearsing, even rehearsing in your own mind is extremely important. And I think that helps to, quote-unquote, demystify this procedure, as Kevin mentions. I think that the procedure itself is relatively straightforward, but when you have to do it, you really want to ensure that you are not hesitating when you need to manage this patient's airway. After all, this is a patient whom you cannot otherwise ventilate or intubate. So going through this is a fairly straightforward procedure, but just like anything else we don't do on a regular basis, we need to rehearse it. It has to be at the forefront of our mind, and we have to be ready to perform this procedure at any time it is indicated.
Let's get into it. Kevin Colopy.
So it was exactly 29 minutes ago I realized I get to follow Abernathy. I've seen the agenda for the past 5 months and it never connected that. So, it's always nice to go after someone who puts such a great presentation together, but a little intimidating too. So we're going to talk about surgical airway management. Like yesterday, I can't stand on a stage, so I'm going to walk around a little bit because my ADD will kill me. Are there any anesthesiologists or CRNAs in the room? Good. I like to throw that out there whenever I talk about airway because they are the only airway experts that are out there. Anyone else in emergency medicine, pre-hospital care, nursing care, we can be passionate about the airway, but we are not the experts because we didn't go to school to learn how to manage airways. So we need to spend a lot of extra time practicing, and the reality is none of us have probably spent enough time practicing the airways. I have no disclosures to disclose. I'm a paramedic, so no one wants to pay me to, like I said yesterday, no one wants to pay me to endorse their products. So we're going to talk a little bit about surgical airways, how they get performed in pre-hospital care, the different forms of surgical airways that are out there, and why it's important for us to talk about. So when we talk about cricothyrotomy, needle crics, open crics, there can all be very different procedures trying to accomplish the same thing. Collectively together, they are a surgical airway, which is one of the most invasive procedures we can perform in pre-hospital care and most of emergency medical care, and it is the most invasive airway procedure that we can perform. And the reality is most of us in this room will go our entire career without ever performing one on a live patient. If we look on the limited data that's available and how often surgical airways get performed in the out-of-hospital setting, there are just a couple of studies for us to glance at. This is a study that looked at 10 years of data at two different level 1 trauma centers, and in 10 years, they had 84 surgical airways that were performed. They were only able to look at 54 of them because of a little bit of missing data. Only 11%, or 6, were done prior to emergency department arrival. Of those 6, 100% of them had complications. That does not tell us we're bad at doing surgical airways when we do actually have to do them, but it's really telling us we have to know it's not going to go well and plan and drill for that. We have to be prepared to manage the complications that will arise. If we look at some of the data that came out in 2015, there was a great analysis that was done that looked at every single data point that was submitted to the NEMSIS data set, which was just over 11.5 million transports. Of 11.5 million transports, just over 400 surgical airways performed across the country. That is less than 0.1% of all transports. That's an important number to keep in mind, because if you have a partner who says they have done 5 surgical airways in the last month, walk away slowly. They are either the worst airway manager or the biggest shit magnet you are ever going to work with, that you'll either get a lot of experience really fast or going to find yourselves in a lot of trouble. This is not a common procedure. So let's look at ourselves. There is only one study that's out right now that has looked at critical care or medical transport in the United States and on what surgical airways we have performed. And they looked at 15,000 transports and found 17 surgical airways. So again, we have a very low number. What's nice in this study is they got them all. So while we were able to perform it very successfully, they still had a nearly 60% mortality rate. I'd like to flip that around and look at it the other way. When we have to do surgical airway, can we all agree if we don't, that patient's probably going to die? So when we do it, 41% of the time, those patients who will otherwise die live. That's actually pretty decent data when we think about it. So let's talk about surgical airways for a second and put them in perspective of airway management, and why is it important to change our paradigm on airway management. Surgical airways are one of the only 2 options we have for a definitive airway. In anesthesia, a definitive airway puts a cuffed tube in the trachea beyond the vocal cords, and that cuffed tube is going to protect us from aspiration and allow you to deep suction the trachea. Blind insertion devices are great alternate airways, but do not provide those 2 pieces of protection. So there are many patients that are out there for which you either need protection from vomiting or aspiration and bleeding into the airway, or the ability to deep suction the trachea. If you have one of those patients, blind insertion devices are really not a good option for you, and you're better off going to surgical airway earlier if you can't intubate than waiting until it's a crisis. So we really, by definition, need surgical airway when you cannot intubate, cannot ventilate, and cannot maintain saturations above 90%. If you have all 3 of those, no lawyer in the world will successfully sue you for doing a surgical airway, and no organization worth their weight in salt is going to not stand behind you when you can objectively document these 3 situations. I hate the idea that a surgical airway or a cricothyrotomy is a last-ditch effort. That's BS. You should be able to go directly to surgical airway because it is a completely reasonable alternative in your airway management toolkit. You should not be using it because you're not good at what you want to do in managing the airway. You should be doing it because you recognize you have a situation where that's the best way to manage your patient's airway. So what airways are we talking about? Well, there are medical airways and traumatic airways where we may need to go to a surgical airway. The only one I thought I was going to have to do in my career was a guy who took a shotgun to the entire front of his face. Fortunately, there was a medic who just came back from Afghanistan who had seen that about 27 times in the last 6 months prior to that and was able to manage the airway for me. And I do mean that for me because I would have been doing a surgical airway. The last one I thought I was going to have to do, we had video laryngoscopy, and my partner was able to intubate the patient before I had the surgical airway equipment ready. He fell 40 feet face first onto concrete. So twice in 17 years, I thought I was going to have to do it. But there are plenty of patients that fall into this list where we may need to consider it that's out there. So if you're going to do a surgical airway, what you need to have drilled is that you are going to set up and prepare the same every single time. Your setup needs to be standardized. If it's not, you're setting yourself up to fail. We want the patient in a neutral position. If you look at the videos, if you look at the discussions, in most true airway management, we want to bring the tragus of the ear in front of the sternum. We don't want that in surgical airway. If anything, you want it in a neutral position to now the head is actually tilted back slightly to try and stabilize and straighten the trachea. We are no longer bringing the head forward as we do in typical airway management. We want to clean the patient. This is not cleaning the patient. What you want to do is provide a good cleanse with povidone iodine or an alcohol swab in the ideal state. Think 30 seconds, scrub the hub. We've all talked about that. The reality is your patient is dying. You need to do something to cleanse the site. You can't ignore infection risk, but you have to weigh cleaning versus my patient's actively dying in front of me. If you have time to clean for 30 seconds, you really need to stop and pause if this is really the right procedure for your patient. One thing we do not do well, if you don't have a physician in your program, is anesthesia at the local site. You will not find this in any critical care transport textbook. You will not find it in any paramedic textbook. You will rarely find it in any blogs or any discussions. But it's actually something that's pretty reasonable and safe to think about doing. Injecting the site with a little bit of lidocaine and a little bit of epinephrine will do two things for you. It provides a local anesthetic, and the epinephrine can cause some vasoconstriction of your capillaries and may reduce bleeding for you. This is not something you can turn around tomorrow and do by yourself. You need to have a real in-depth conversation with your physician leadership on if this is something that's reasonable for you to do. The downside is if you inject too much into the soft tissue, you can obscure your ability to actually be able to palpate the structures you are looking for. What you should always have time to do is provide proper analgesia. Even if you are not going to provide local analgesics, provide systemic analgesics. Give the patient some fentanyl, some ketamine. Do you need sedatives? Maybe, but they are not analgesics. They can potentiate analgesics, but they should not be considered a standalone intervention when you're getting ready to manage the airway. You cannot forget about upper airway management. Too often we forget about this aspect, and it's important if you are using any sort of device that is not going to put a cuffed tube in the trachea. They've actually studied and looked at the different devices that are available to us and compared both cuffed and uncuffed surgical airway devices that are out there. And they have found that if you have 3 millimeter holes above where you are trying to ventilate the patient, you will lose about 20% of your volume. If you have a 5 millimeter hole above where you've tried to plug the airway, you are going to get about 20% of your intended volume in. And if it's a 15 millimeter hole, you're essentially ventilating the air. What it looks like on a graph is this. So what it means is you actually, if you are going to use a surgical airway device or modified kit where you end up with an uncuffed tube in the trachea, you literally may need to duct tape the face shut. It's going to look a little weird when you walk in, but if you have any holes in that upper airway, you're not going to be able to effectively ventilate the patient. So let's prepare ourselves for our surgical airway. You want to prepare, like we said, the same every single time. So you want to stand on the same side of the patient every single time. Yes, that means you may need to take the patient out of the back of an ambulance so you can do it outside, so you can do it the same. Set yourself up for success. This is already a high-risk, very low-frequency event, and you want to be able to be as successful as possible. Move the patient into your position so you are ready. It's the patient's crisis, not yours. I like to stand so my non-dominant hand is towards the head so I can rest my hand on the chin and palpate the structures with my left hand, and then I have my dominant hand towards the chest so that I have it to play with all my tools. We're going to stabilize the neck then and the trachea between your thumb and your index finger, middle finger, and have your index finger available to palpate your structures. So that brings us to our 3 different options we have for surgical airways. We have needle crikes, open crikes, and then we have really everything in between that's going to really follow a Seldinger's technique or a modified technique to get us to airway management. Needle crikes have a place. You should never rule out the fact that you could need needle cricothyrotomy, particularly in kids or in very unique situations. You want to have as large of a catheter as possible. In adults, it's a 10 to 14 gauge needle. Yes, they do still make 10 gauge IV catheters that are out there. You can get them if you're lucky. They're kind of large, but they work. And then what you want to have is a 15 millimeter adapter off of your BVM. I highly suggest, since you clearly can't buy these kits, that you pre-manufacture it. Have your BVM ready, a needle, and a 10 cc syringe filled with water. I take my catheter and I put my syringe half filled with water on my needle, and as I am poking through the cricothyroid membrane into the trachea, I am aspirating so that we can all see the air bubbles as we aspirate the air inside of the trachea. I find having the air bubbles there as a visual cue for everyone lets people to not just trust that, okay, I don't feel any pressure as I'm aspirating anymore, but we can all see as we aspirate there's a consistent flow of air bubbles, which is more likely to help us stay in the trachea. Once you remove the needle, you then take your meconium aspirator, attach it to the 15 millimeter adapter, attach it to high flow oxygen, and when you want to oxygenate the patient, cover the hole of your meconium aspirator. The key phrase here is you will oxygenate your patient. You will not effectively ventilate a patient with a needle cricothyrotomy. And that is simple gas laws. You are not going to effectively get a flow of air back out through that needle, but you can, with high flow oxygen, continue to inject more air into the trachea and have it move and diffuse down towards the alveoli. And even as the pressures of the carbon dioxide rise, you will still be able to get oxygen into the patient's lungs. So that brings us to Seldinger's technique, which is a great step-by-step process for airway management that's available to us. However, it involves a lot of steps that you can see here. You're going to start by isolating the trachea very similarly as we will to needle cricothyrotomy. You're going to insert a needle, but now we are going to use a specialized wire through the needle to put it down into the trachea. We then remove the needle and perform a vertical incision vertically along the length of the needle. You will see in the hospital and other places where you can do horizontal incisions. It's not technically wrong to do one. The best answer I can find for why you want to do a vertical incision is so when you cut in the wrong place, you only have to extend the hole. You don't have to make a whole new incision and cause additional bleeding. There was a blog on Facebook on one of the flight paramedics and nurses pages several weeks ago where someone was getting yelled at by the respiratory therapist and asking if they did something wrong because they had too long of an incision. And the best answer that was on there is, dude, your patient's alive if they're complaining about having to do too much repair. I'd rather have my patient be alive with a large scar than dead. So vertical incision, yes, it does protect you from bleeding. It stays away from the major vessels. But really, when you are likely to cut in the wrong spot, it makes it much easier for you to extend that incision a little bit rather than creating an entirely new hole. We're then going to insert a dilator over that wire. We're going to slide it into the airway, slide our airway over the dilator. So there are multiple steps to this technique. If you don't do this a lot and you don't practice it a lot, I find the more steps you have, the easier it is to make mistakes. You're going to miss something. Seldinger's technique relies on you following each step in order without missing a step. It is great if you are going to practice it and drill it down. Then it becomes a very realistic option for you. The problem I see in too many systems is they practice this once a year on skills day. This is not a skill we can just practice once and forget about. You have to be perpetually practicing this on a regular basis. There's a reason at our program we have airway heads at all of our air bases, and we make our crews sign each other off to say, I have actually performed intubation today at the beginning of my shift. And they do it every single time, and I collect the forms every month. Fortunately for us, there are several modified Seldinger techniques that are out there that come in manufactured kits that simplify the process and make it easier for you. My program currently uses the Quick Trach 2 because it's 3 steps and allows us to very quickly put a cuffed trachea or cuffed tube in the trachea. It's quick, it's easy. Is it necessarily the best? No. But we have a hard time. I've had one surgical airway in the 5.5 years I've been at my program that we've had to review, and I have a very hard time going away from a commercial device that's designed to do this than going to the next step, which is open surgical airway, and having more tools, more risk for my patient when I have a device that simplifies the process for me. So open cricothyrotomy. It allows you to put an endotracheal tube into the trachea. You need a scalpel. You are going to perform a surgical incision, and you end up with the largest airway probably possible of all your surgical airway options. So we're going to stabilize the trachea, identify the cricothyroid membrane once again, make our vertical incision similarly as we did before, and once we're in the trachea, What I like to do is I pop through the cricothyroid membrane, I take my scalpel and I turn it 180 degrees to widen the hole. Makes it a little bit easier for me, and then we hold the scalpel in there. We've all heard, never abandon the hole. You don't want to, you'll never find it again. It's a bloody mess, you'll never get back in. The reality is you've just cut a hole in the patient. That hole is there. You will be able to stick your fingers back into it and find it again. The problem is most of our patients are not very thin anymore, and there's a lot of adipose tissue here. And as you go back in to find it, it's not the blood that's going to get in your way, it's all the connective tissue and fat that's in the neck that's going to make it harder to get back into the trachea again. So if you lose the hole, it's not the end of the world, it's just going to suck for a little bit longer. So you don't want to abandon the hole, but if you do, don't fret, don't panic any more than you already are. So ideally, you've left the scalpel in place until you can catch the trachea and grab onto it with a tracheal hook. The tracheal hook is a great ideal tool if you have it, but they can be fairly expensive. And if you can't, use this set of curved hemostats. Grab it, open it up, place the hemostats in there, and spread them open so you can catch both sides of the trachea. You just want to be honest and document what you used inside of the trachea, so when the pulmonologists have to go back in later on and evaluate the inside of the trachea, they know what you've done inside of there. And when they see damage, they see soft tissue injury, they can relate it back to what took place. It's just important to be honest. So we used curved hemostats. With the curved hemostats in there or the tracheal hook in there, slide your bougie down in until it gets stuck at the carina. If it doesn't get stuck, you're either in a false passage or you've managed to perforate all the way through the trachea and into the esophagus. Just like when we use the bougie in regular intubation, you want to insert it until it gets stuck. Keep in mind, though, you've eliminated all of your dead air space above the cricothyroid membrane, so it will not appear to need to go in anywhere near as deep as you otherwise would expect it to. With the bougie in place, you can then take the hemostats or your tracheal hook out, and then you slide your endotracheal tube in over the top of your bougie. You, again, only need to go in so that that cuff goes a centimeter or two past your hole. You want to make sure it's in, but it's very likely to go deep with surgical airway. That said, you can live with one lung, and I would rather be deep and alive than have it falling out on me on the way to the hospital. So once you get your surgical airway in place, you do have some post-intubation management to take care of. You need to confirm your airway. That should go without saying, but sometimes when we get in high-risk, low-frequency events that we haven't properly drilled ourselves for, we skip otherwise obvious simple steps when we're talking about it in practice. Colorimetric capnography is probably not ideal for us because the amount of fluid and blood that we are expecting there. You really want to go to waveform capnography directly with these patients. If you need colorimetric, fine. Use it because someone says you had to, but if you have waveform, colorimetric is really a useless tool. Secure the airway. Use twill, use cloth, or what I really like, I haven't done it myself, I'll be honest, staple it in place. The patient's going to have to go in for reconstructive surgery on the neck anyway at some point. Stapling it is probably one of the best ways to secure it in place, and if the patient is bleeding, you're going to have trouble getting anything else that's stuck there. Again, I'm not saying go and use a stapler tomorrow. This is something you need to practice with your physician leadership at your program and have a plan for before you go ahead and practice it, but it seems reasonable if you really want to secure an airway that otherwise was near impossible to perform. And then you are going to need to bandage and control the bleeding that takes place. And you also want to be mindful of the high risk for an air leak with these patients. Expect subcutaneous air to develop if you have a little bit of an air leak. If you don't have that cuff properly inflated, you could get air coming back around the sides, and you need to be prepared to manage it. And it's not something you can really practice on a regular basis unless you get in and practice on soft tissue. So let's talk about practicing this. Surgical airway, like we said, is something you cannot just do once a year. It's something you really need to practice. So they've actually studied on residents how long it takes to develop and practice and perform. And what they have found, and this was a study that looked at the different options that are available, they found you can more quickly perform surgical airway using a Seldinger technique than an open surgical airway. However, that difference is probably not clinically significant. What they did find that was important is the comfort level stayed there in the Seldinger technique later on. They felt more comfortable with it because it's a defined process. So are there contraindications to surgical airway? Of course. We're going to talk about those in a second. If we don't talk about contraindications to something, we're doing it a disservice. What you need to remember is it's really the technique that's probably contraindicated, not the fact that you need to do it yourself. Because if we don't do a surgical airway in a patient that needs it, they're probably going to die or suffer a severe anoxic brain injury. If you do it on a patient where there are a lot of relative contraindications, you risk improperly placing it or causing additional complications that you may not be ready to manage. So short is the mnemonic for the contraindications for out-of-hospital surgical airway. The only true absolute contraindication that's on here is the inability to identify your landmarks. If you can't palpate the cricothyroid membrane and identify where you need to be performing your incision and attempting to access the airway, you have no business, unless you have MD or DO behind your last name, cutting the patient. Those guys have malpractice insurance and years of additional training that no nurse or paramedic or anesthesia that has out there, and unless you're a physician, you really shouldn't be cutting there. And I'd be hard-pressed to find a court case, there isn't one out there, where letting someone die because you couldn't find the right place to cut on a patient was thought of as better than blindly cutting in the pre-hospital setting. The closest thing we have would be the paramedics who did a emergency C-section with online medical direction on the Upper East Coast a couple of years ago, and they both lost their licenses even though they saved the child's life because they did something blindly that they, even though they had orders, they were not properly trained to perform. No paramedic or nurse is trained to blindly cut into the airway. So training. Training is something you must do on a regular basis. Surgical airway management needs to be program specific. It is not something you can have done in your critical care class or have done in school or have done once or watched a video online. You need to have a formal lesson on it, whichever process you're going to follow. You then need to practice it and you need to demonstrate competency. And those two pieces are not done at the same time. Practicing it is the opportunity to ask questions, walk through, stumble through, learn. Competency demonstrates not only your ability to perform the skill, but recognize when and where it needs to be performed. So then there are some ongoing training questions that occur once you have demonstrated competency. Question is, how long do you need to wait? If we follow CAMES, they say no more than once a year between your high-risk skills labs. So that's no more than once a year. That doesn't say you don't need to practice it for a year. It's saying at most you can wait a year. The question really comes down to how long should you wait. If we look at, again, residents and how they have performed surgical airways in the study session, and this is on anesthesiology residents, they found that before training, they struggled. This is the time it took to establish an airway. But with formal training, they were able to maintain the same level of comfort and approximately the same amount of time it took to perform the procedure on day after testing at 3 months, 6 months, and 12 months. This is the only study that's out there right now that has looked at how long we can demonstrate competency and then wait for retesting or revalidation of the competency. And yes, they have shown that at 1 year you can still be competent. But that doesn't mean you can never practice it throughout that year. Surgical airway management is a very high-risk, low-frequency skill that if you're lucky you will never have to do. But just because you may never have to do it does not mean you should not be ready to do it tomorrow and every single day you go to work. The worst thing you can say on skills day is, well, I'd have to look that procedure back up. Because the day before that, you were competent to practice it according to rules and regulations. So you need to be comfortable every single day of the year in performing this skill. It is a rarely used procedure for cannot intubate, cannot ventilate situations. The device you use, you need to be very comfortable with. It's going to be organization specific. There may be state regulations that define what you can do in each state across the country and around the world. But whatever it is your individual responsibility to be comfortable with that procedure and know it inside and out.
Folks, we really hope you enjoyed that lecture by one of the nation's best pre-hospital educators. Now, we have to remind you, this was just a little taste of everything that CCTMC offers. There's nothing like attending CCTMC in person. So let's kick it to our IPP, our immediate past president of AMPA, Dr. Chris Fulligar, to give you all the details for CCTMC 2018.
This last CCTMC was, I think, the best one we've ever had, and I'm really excited about 2018. So mark your calendars now. It's going to be April 9th through the 11th, 2018, at the Wyndham San Antonio Riverwalk in San Antonio, Texas. We're also going to be having our pre-conferences the weekend before, so keep those dates open. Look out for the registration link, and I hope to see you there in 2018.
Chris, these pre-conferences are amazing too. So if folks have attended CCTMC but not come the weekend before, we definitely encourage you to check that out. This last go around with Dr. Jack Davidoff as a medical director, the surgical skills and cadaver lab were just incredible. I've never participated in an anatomy and procedural program like that anywhere in the country.
Yes, it is something that we continually get very positive feedback from, and something we continue to work on each year to make it better and better.
So lots to check out there, folks. Mark your calendars. You do not want to miss CCTMC 2018 San Antonio, Texas. And with that, this is Faizan Arshad and Chris Fulligar wishing everyone a safe tour and a happy EMS week.